Hello, everybody. If you can take your seats, we'll start very shortly. So while people are taking their seats, I just want to introduce the conference. So thank you very much for coming. My name is Boyd Gosh. I'm the current president of the BNPA. My colleague who's going to be joining me, Vaughan Bale, is just sitting over here. He will be starting as of 3 days' time. Thank you for coming. We have a change of venue this time. It is a bit more cozy. It is therefore a little bit cheaper. So hence we've been able to change the pricing slightly. So apologies for the coziness. Hopefully you've appreciated the change of pricing. So in my 3 years of presidency, we've done a few talks. The first year we talked about how we as individuals, as people, are different and how that changes how we might perceive or get diagnosed with disease and what diseases we might suffer from. In the second year, we talked about environment and how context and environment around us changes the diseases that we present with. The third year, this year, is all about treatment, so we've got lots of stuff for you. We've got some things about traumatic brain injury. We've got some stuff this afternoon about functional neurological disorders. And this morning, we have an impulsivity session, which I'm going to hand over. And one of the speakers I should just mention is my former mentor and supervisor, James Rowe, who will be talking about impulsivity in conditions that I'm particularly interested in. I probably should say some sensible grown-up things like we're not expecting a fire alarm. If there is a fire alarm, there is an exit over there and an exit behind. There is a breakout session at for people if we don't have rooms later. If we don't have room in here, there is a breakout session in one of the breakout rooms where you can see things remotely. For the people who are remote and online, we will do our best to check your questions and then answer them in the Q&As afterwards. And thank you for joining us. Hopefully you'll enjoy the conference, and I'll hand over to our chairs. Thanks.
Great, thank you, Boyd. So, welcome to the opening session of the 2025 BNPA. I'm Jeremy Isaacs. I'm co-chairing this session with Professor Garfinkel, who's sat to my left. And it's a great pleasure to welcome two fantastic international speakers to kick off our session this morning, which is on a general theme of impulsivity. Our first speaker is Professor Hugh Garavan, who's come to join us from all the way from Vermont. And Hugh is a psychologist and has a very impressive CV, as you'll see in the biography in the program. And I want to start with an apology, and this is my impulsivity. We've added an apostrophe to your title in our program, and that's very, very distressing to me as an English language pedant. But anyway, you've wisely not used it. Right, so Hugh, it's a great pleasure to welcome you to the BNPA, and we invite you to give the JNMP lecture. Thank you.
You've made me all sorts of anxious now about my apostrophe, so I'm guessing it's impulsivity and it is role in psychiatric disorders. This is my presentation. Hi, everybody. It's a tremendous pleasure to be here. Thank you so much for inviting me. I'm delighted to be here. I realize that this society, like all societies, is 10 minutes late in starting. That's not so bad. So I will try. I already speak too quickly, but I'll try to speak even faster and get through to this morning's content. So apologies if I go too quickly. Okay, let's get into it. So I was asked to give a sort of just starting general overview about impulsivity. My bias is, so I'm a cognitive psychologist, cognitive neuroscientist. My bias is functional brain imaging, longitudinal studies, adolescence. So that's kind of going to permeate what I'm going to present today. But this, is what I'll talk about. Just give a bit of background, again, on varieties of impulsivity, a little bit about the neurobiology, but not in any great depth. Talk a little bit about developmental trajectories. Obviously, impulsivity is interesting in terms of just, typical neurodevelopment, especially through those adolescent years, and and any dysfunction or disruption that might happen to that neurodevelopmental trajectory is seemingly related to a whole number of neuropsychiatric outcomes. And then, because you have a focus on treatment, I'll present, it's not something I do, but I'll present you just one slide on treatment related to impulsivity, just to kind of finish off on a positive note. Okay, all right, here we go. So let's get started with impulsivity. And again, this is not a good idea. Okay. what has happened is that my computer has decided that this is the optimum time to update its software. So, and this is something that my university insists that our computers have, which is really delightful. So let's hopefully turn that off. Lots of things are going wrong in US academics these days, as you might imagine. This is probably the least of them. Hopefully that should come back up on screen now. There we go. Okay. There's got to be a joke about what just happened in Varieties of Impulsivity, but I can't quite figure it out. Anyway, okay, so basically let's get into some of the content. And apologies if this is, very well known to many of you, but just sort of bear with me. But generally in the study of inhibitory control, it divides into two large categories, sort of impulsive responding versus impulsive choices. And that's kind of traditionally studied for impulsive responding with go, no, go tasks. So, a whole bunch of stimuli, one at a time, go, 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 on occasion inhibit. And it can be as simple as respond to every number on screen except the number 3. And here the rule is X, Y, X, Y. As long as they keep alternating, keep responding. If the alternation breaks, don't respond. So if it's an X followed by an X, inhibit responding. But it's just simple kind of goes and no-goes. And then the other major task in this domain is the stop task. Again, you're given a pretty simple task. If the arrow points to the right, point the right key. If it points to the left, point the left key. Do that repeatedly. And then on occasion, after one of those arrows, a second symbol will pop up on screen and say, stop. So you're about to make that response, abort it, inhibit. Those two tasks kind of capture a large bulk of all the inhibitory control, at least the brain imaging studies. And then the other one, again, you're probably quite familiar with, sort of impulsive choices, which is one way to think about this. These sort of, sometimes it's potentially a pejorative way to characterize it, but delayed gratification, these kind of choices people are given, do you want £1 now or £10 in a month? People tend to discount the value of a reward as a function of how long you have to wait for it. So with these types of questions, you can calculate somebody's discounting rate. And again, that seems to have interesting brain correlates and be different in a number of different neuropsychiatric conditions. In terms of the brain imaging, Neurosynth is this kind of big database that you can for meta-analysis. If you type in motor inhibition, you'll see largely prefrontal regions, midline, right dominant for the most part, and I'll come back to that in a second. And for impulsive choices, again, like I say, you can calculate per participant the extent to which they discount, the speed at which they discount a reward as a function of its delay. And then the brain imaging, or at least the brain science on that, is quite complicated. There's multiple brain regions involved, but also, subcortical reward-related regions are seem to be quite important. So those are two major domains, and will be the bulk of the brain imaging studies that you'll see. But of course, I think part of what makes impulsivity interesting is that it's such a broad umbrella term. So there's a whole bunch of other things that we could be talking about. So suppressing emotional reactions is another type of impulse control or inhibitory control. And again, there's a world of tasks that do, engage these processes. So you might show individuals evocative stimuli and have people just respond to them, versus show them evocative stimuli and have them try to suppress their response. And you can gauge and measure how well people can suppress their response with behavioral reports, with physiological measurements, and with brain imaging measurements. So this is often used, for example, for suppressing reaction to drug cues in individuals with substance dependence. You can suppress attentional biases. So very many tasks will just present stimuli and say, just ignore the stimulus in the middle. I want you just to identify what's the color border. So the stuff in the middle is, irrelevant. But of course, if it's evocative, it'll slow people down. And again, my bias for today's talk will be substance dependence. If it's substance dependent related stimuli, it'll also slow people down. So you can use these sort of tasks to kind of engage people's attentional bias, their, if you will, inability to attend to suppress, to inhibit responding to, in this case, drug-related stimuli. You can make those sort of things even slightly more cognitively demanding. So you can give people a memory set. So remember those 5 numbers. I'm going to present a number on screen, and you just have to push a button corresponding to the next number in the memory set. So if the number 4 pops up, you would enter the number 1. There are pictures in the background. Don't worry about them. But if they're evocative, that tends to slow people down. And if you're a substance user, if they're drug-related, that also slows people down. So again, just another example of testing people's abilities to inhibit responding to drug-related stimuli, and so on and so forth. And then, as you might imagine, there's a whole bunch of cognitive tasks that you could say tap into impulse control or inhibitory control. You all know the Stroop task. The challenge in naming the font color is that you have to inhibit the more automatic response to read the word. Reversal learning tasks where, you know, one cue is rewarded repeatedly and then it's just not, and then you have to suppress responding to it and make the switch to the other cue. And, you know, set shifting tasks, gambling tasks, and a whole bunch. So part of this is, you know, the purpose here is obviously just to kind of give a sense of the varieties of impulsivity, but also just to give the take-home message. That's probably quite clear. Like, it's an umbrella term. It's what makes it interesting. It's maybe why it's the focus of this morning's session, but it probably encompasses a whole bunch of different aspects of impulse control, and how well correlated these types of impulsivity measures are tends to be a bit sobering, because you might give this battery of tasks, and actually they're not very highly correlated with one another at all. So again, it's probably a construct that needs a lot more, I don't know, decomposition and explanation. But be that as it may, it doesn't stop us from jumping into trying to understand the neurobiology. Again, I'm going to try to go quickly. I'm not going to talk about this in great depth, but as you all well know, there are these well understood cortico-subcortical loops involved in, you know, thought reward processing, emotional regulation, sensory processing, attention. But the one to the left is the one that, you know, would be of most interest for the sort of motor inhibition. These circuits are very well understood, right? So these frontal subcortical thalamic loops, these direct pathways, indirect pathways, hyperdirect pathways, the mechanisms involved in inhibiting motor signal and disinhibiting the brakes on motor signal, very well understood at this stage from, you know, animal models. So these mechanisms for that very simple sort of just motor inhibition, well understood. We can then take this into the scanner. You know, so okay, if this is an interesting construct, can we get useful measures of it, probes of it? So this actually brings me back to research I guess I'd done quite a while ago. So again, this is a straightforward go-no-go task. Respond as when the letters are alternating, but if the letter ceases to alternate, if you get an X followed by an X, just inhibit your responding. So again, just a very simple idea, just it's a go, 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 inhibit, go, 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 inhibit. You do that. This is back in the day when 71 participants was considered a very large sample size, but now we know for some types of analyses we need thousands. But for a group map, 71 is actually plenty. So, you know, largely right hemisphere patterns of activation, right prefrontal, right parietal, right inferior frontal gyrus, some on the left as well. We can triangulate this with lesion studies. So lesion studies have tried to map where brain damage is most associated with impairments on this task. If you put the lesion maps together with the brain activity maps, you get, you know, right prefrontal activation. So right prefrontal cortex seems to be a critical node in the circuitry. We can look at this another way using TMS. Part of this overview is just kind of mention some of the methods, and my favorite method is coming up in a few seconds. This is TMS, so, you know, disruptive TMS. What we found in this study is that very specific, if you do disruptive TMS at right IFG, you disrupt response inhibition. You don't see that if you do it over the more dorsal regions or over the parietal regions, or indeed over the left hemisphere regions. So again, converging evidence that right IFG, right inferior frontal gyrus, seems to be a critical node in the network. One more piece of converging evidence. This is a little bit busy, but I'll just kind of cut to the chase. We can study the ability of a split brain patient to do the task. So while they're maintaining central fixation, we can present stimuli in the right visual field, so testing how well their left hemisphere performs, or in the left visual field, testing how well the right hemisphere performs. Miscellaneous variances on go, no go, and stop task. The details don't really matter. But essentially, you know, the left hemisphere is not catastrophically bad, but the right hemisphere is a lot better at inhibiting. And then finally, my favorite, the definitive test that this is a right hemisphere dominant response, and this is something you can try at home if you wish. So, you know, you think your life is tough. Some graduate student actually had to do this study, which involved counting the direction in which the dog's tail wags. So this is sort of the right hemisphere, the the big picture here, this sort of a big heuristic is that left hemisphere, and I'm not a huge fan of these kind of right-left biases, but be that as it may, but that the left hemisphere is involved in more reward, appetitive behaviors, and the right hemisphere is more involved in withdrawn, inhibitory behaviors. So what they did to test this is that they showed a dog, and I may as well start showing you the video, a picture of its owner eliciting a left hemisphere approach response, which would bias its tail to wag to the right. And then they presented a picture of another dog, which would elicit a right hemisphere avoidance response, which would bias its tail wagging to the left. And that indeed, thanks to some poor unfortunate research assistant who actually had to count and measure tail wags, is exactly what they found. So this is one way you can figure out, I guess, if your dog does actually like you when you get home. Okay, how are we doing time-wise? We need to move quickly. Okay, developmental trajectories. So there's a couple of big studies I just want to mention to you. Again, my bias, my interests are in, for the most part these days, adolescent development. Again, I think you all know this. Many neuropsychiatric conditions develop during the adolescent period. There's substantial amounts of brain development happening, all sorts of physical, social changes happening from ages 10 to 20. So there have been a couple of rather large longitudinal studies. So one that came out of the Institute of Psychiatry here is the Imogen study. It measures, for our purposes, a motor inhibition task, that stop task, as well as other tasks that we don't need to focus on. Pretty extensive battery of assessments, but the best thing about it is that these kids, about 2,000 of them were measured at age 14, which involved brain imaging, again at age 19 and again at age 23, and are now being assessed, but without brain imaging now that in their late 20s. So we have about 10 years of longitudinal brain data on about 1,500 participants, which is, it's a great resource. It's a great data set. And the task that we have in this was, again, that motor inhibition task. So again, you can critique the task, like, is this really tapping into aspects of inhibitory control that are of interest? Because it's such a simple task, go, withhold a response. But, it does engage brain regions that do seem to be implicated in a whole bunch of other psychiatric conditions. Okay, but cutting kind of quickly to it, what we did for this analysis is, we took advantage of the large sample size. We just did factor analysis to see if we could identify networks of brain regions. And just to kind of quickly, this is published, so I don't feel too bad about going through it quickly. But, we identify a number of brain regions that are active during the task. The factor analysis here groups the brain regions into different networks, if you will. As you might imagine, because it's factor analysis, the regions that clump together are highly correlated with one another, but the networks are not correlated. But there's, minimal correlation between networks. And then we can see, what are these, related to. That doesn't really matter. But what we can see is, which of these brain networks are related to, for example, substance use. And we can see that here the more lateral orbitofrontal cortex and motor regions tend to be correlated with, this is age 14, substance use levels. Kids reporting elevated ADHD symptoms actually didn't show any deficits or any differences in these inhibitory control maps, but they did in the sort of behavioral monitoring. So another measure you get from these tasks is when people make errors, and we can look at their ability to kind of monitor their behavior and self-regulate. And that's where the ADHD kids showed differences in activity. So, maybe some sort of a dissociation here between brain regions that are implicated in substance use versus brain regions that are implicated in ADHD. We can find which brain regions, which networks are related to just better performance. Which kids have better inhibitory control, what seems to be related to that. We can also look for genetic correlates. Again, we won't go into the details, but in this case, there's a gene related to the norepinephrine or noradrenaline transporter gene. Doesn't matter. And also, again, we can do a little bit more in-depth analysis on these right prefrontal regions and show that they're implicated in, are related to substance use. Again, I appreciate I'm skimming the details here, but I think kind of the purpose is just kind of give you the big picture of the types of research questions that we can do. And like I said, these are published papers anyway. I want to get on a little bit to this, the ABCD study. So this is a study in the US that pretty much consumes all my time, but it's a fairly great study. I don't know if any of you have heard about it, But what we've done in across 21 sites in the US is recruit about 12,000 kids. And by design, over 2,000 twins, half of them monozygote, and not by design, just by happenstance, 30 triplets. I have no idea what the research question might be with 10 sets of triplets, but somebody should do something with them. And we're following these kids for at least 10 years, and hopefully thereafter. But we have very rich annual assessments on the kids. The assessment battery is about 7, 8, 9 hours, as well as from their caregivers. Very and brain imaging every second year. So brain imaging at ages 10, 12, 14, 16, 18, and hopefully thereafter. But very extensive neuroimaging, genotyping, psychometrics, hormone analysis, geocoding, which allows us to link with a whole bunch of other data sets on environmental measures and what have you. And the important purpose, an important thing to note, is these data are publicly available. So we make these available to the research community, so the research community has the same level of access to these data as we do. So it's a fairly phenomenal resource that is available if you're interested in these sort of adolescent developmental issues. There's a stop task. I won't go through it, but surprise, surprise, shows robust brain activity for inhibiting, for making errors, robust correlations with individual differences in ability on the task. We're at a very exciting point right now in that our next annual data release is going to include kids from ages 9 all the way up to age 18, right? So what this is just showing you here is just kind of cortical thickness development. So, neurotypical development, which show thinning or apparent thinning of the cortical thickness. We can quantify that. We can look at regional differences in that. So of course, maybe it doesn't need to be said, but we'll say it anyway. The whole purpose of this study is yet to come in many ways. There are going to be all sorts of interesting outcomes. So with 12,000 participants, a non-trivial number will develop eating disorders or psychosis, or will be tremendously successful, or will develop, will attempt suicide, or will be successful in suicide. And the whole purpose of this is then we will have very rich longitudinal data. And the whole idea then is once we have these kind of interesting outcomes, to go back and see, well, was there anything in their developmental trajectories in this huge big mess of cognitive measures and psychological measures and home measures and genetics and brain? Can we predict, can we retrospectively predict those outcomes, and that might give us insights into etiology. So now that we're starting to get these sort of developmental trajectories, and the kids are now 16, 17, 18, so we're getting more and more interesting outcomes. The data set becomes ever more interesting. And like I say, and it's available to whoever wants it. So as well as looking at just brain development, cortical thickness, obviously we can look at performance. So, their ability on the stop task gets, better and better. And what's of particular interest, if you're interested in these, in the brain activity, is we can look across the brain and see, well, what sort of brain changes accompany improvement in impulse control, or subject to the adversities, or who knows what, the life circumstances that might happen. We can look across brain regions. We've developed a tool that's available where you can go like vertex to vertex, vertex-wise, and just kind of see what the developmental trajectory is. We can see, well, what brain regions seem to have similar developmental trajectories, what seem to be different, what's related to miscellaneous phenotypic differences. Those types of questions. Okay, I appreciate that. We're probably at 9:30, a little bit thereafter. Another thing we can do with these brain data is we can create these kind of multivariate classifiers. So again, without going into the detail of it, but we can look at the patterns of activity across the brain and try to come up with the best measures of what discriminates the brain when it's inhibiting from when it's going, and then use that multivariate marker of impulse control as a measure of interest, and we can see how well it's related. I appreciate that actually the font is quite small, but basically what that's showing us is that this brain measure of impulse control is related to performance on the task, which is the first line, but then kind of shows some nice specificity. The next chunk, the more activity you show in these key brain regions, the better you perform on a number of these cognitive tasks, and then also the worse you score on a number of the CBCL, the Achenbach scale, measures that are plausibly related to impulse control. So things are like externalizing, aggression, ADHD symptomatology, but not at all related in the bottom few there to more internalizing symptoms. So we seem to be able to get this kind of brain measure of impulse control that seems to show, have at least good face validity for being related to these mental health and cognitive outcome measures. So of course what's going to be really keen is, to see how that then proves to be predictive of miscellaneous other outcomes as these kids age. Okay, last few slides, just by way of treatment, just to finish on a positive. So there's a lot. So this was a very shoddy PubMed search that I did yesterday. So I only put in the word impulsivity, I didn't put in its variants, I only put in a word like addiction, I didn't put in its variants like substance use. But with that simple PubMed search, you'll see just how rich this field is. So, so I decided to abandon any attempt to summarize what we know about impulsivity and psychiatric disorders. But just to come back to my interest, that's a horribly busy slide, but just the point is that this impulse control seems to have some sort of predictive value. So this is, again, coming back to that European study. This is, brain predictors of which kids go on to use cannabis a couple of years later. And the story is complicated, but the point I just want to make is that within all of that mess, you'll see that brain activity doing the stop task comes through quite frequently. So brain regions that are involved in that impulse control are indeed predictive of future cannabis use. In the ABCD study, now flipping to that one, this is not including brain measures, but even just looking at psychological measures, if you can read it there kind of near the top, the UP scales, which measures, kind of a pen and paper measure of impulsivity. A number of those measures are also, that are related to impulsivity are also predictive of cannabis use years later. And what's going to be really interesting now with the ABCD study will be look at the brain predictors and the brain correlates. But the last slide I want to leave you with, again, just to let you know that, again, treatment is not my forte, but there are intervention studies. Again, apologies for a busy slide, but the essential, I'm kind of amazed at how well this research works. What the study does is this is a few thousand participants in Montreal, and identifies kids who score relatively high on personality variables of interest, so things like impulsivity, sensation seeking, and then just has like 2 interventions, 2 meetings with the kids. So if you're scoring high in impulsivity, you get these little booklets that kind of describe what impulsive behavior is like and kind of give CBT-like guidance as to how you can actually deal with these issues in a way other than how you might have in the past. So kind of guidance to try to not be as impulsive when you're responding. And what they find is a whole bunch of outcome measures, but years later, just that small intervention focusing on your own impulse control and giving you some of the tools to try to control your impulsivity seemingly is related to all sorts of long-lasting outcomes. And in the particular measure is the probability of a substance use disorder at each year after the intervention. So you'll see it's quite effective and quite long-lasting. So I think that's also part of the reason why people are interested in impulsivity. There's the sense that it's tractable, it's targetable. There are training methods, and maybe there are pharmacological treatments that can actually address impulsivity, and that could then potentially have long-lasting consequences. Okay, we're not exactly back on schedule, but not so bad. I just want to thank the people who did most of the work here. So, just by way of quick summaries, impulsivity, inhibitory control, clearly multifaceted constructs, but amenable to scientific inquiry. Whether they're the most interesting things to study, I don't know, but they're studyable, right? Which I think is why these kind of motor inhibition tasks are so popular. It's not just because someone has decided they're inherently interesting, but they are amenable to brain imaging studies. So, take that for what it is. Neurobiology is pretty well understood. The development trajectories are becoming, well understood. And of course, the interesting question is individual differences in these trajectories. How predictive are these of future mental health outcomes? And finally, as the data shows, impulsivity is predictive of adolescent behavior and can be a target for preventative intervention. And with that, I will stop. Thank you for your attention.
Thank you, Hugh, for that bravura introduction to the topic. Before we go to questions, could I invite people at the back to come forward? There's plenty of space. It's particularly on the right here at the front, in the front 2 rows, a little bit in the middle on the left there. We know there's enough space for everybody. So do come in. We'll just give you a minute just to settle.
There's a bunch over here too.
Right, so we have some roving mics, and Richard has a question.
Thank you. Hi. My question was about impulse control and response inhibition in ADHD compared to substance misuse.
Yep.
Which you mentioned about there being a difference. I wonder if you could expand on that difference, and also, is there any way of predicting which people with ADHD might develop substance misuse and who might not?
Yeah. So in that one paper, and as you might be aware, brain imaging has all sorts of replication anxiety. So I wouldn't put too much weight. But as we study the brain correlates of things like psychiatric conditions, when you do it in well-powered studies and when you do it with proper cross-validation, the effects are very, very small and not very robust. So the literature, people thought that impulse impairments related to ADHD, they're not as strong as one might have thought. In that one analysis there, what we found is that some of these prefrontal regions were, showed different levels of activity as a function of substance use levels. But we didn't see any inhibition-related regions related to ADHD symptomatology. But instead, in these types of tasks, and apologies if I went through too quickly, one of the nice things about it is that, by design, you very often make mistakes on this task. So you fail to inhibit, and then you see other circuits light up. So brain regions like the anterior cingulate, anterior insula, if you will, a kind of a monitoring or a salience network, they light up, and they're saying, you just screwed up. Wake up, pay more attention. And it was those circuits that we showed lower activity in the kids with ADHD. So sort of inhibitory controlled substance use, but an error monitoring, behavioral monitoring in ADHD, at least in that one analysis. So that's what that finding was.
Dr. Bird has a question.
Hello, thank you, I'm Jonathan Bird. Thank you very much for a wonderful talk. I'm just wondering what you make of the kind of Mark Solms view that we're paying too much attention to the cortex, because that's what we can look at with all these clever techniques, and not enough to the subcortical and even brainstem regions in terms of controlling the background upon which we behave.
It's interesting. So my background is as a cognitive psychologist who studied initially like working memory. So I'm well disposed towards the cortex, I suppose. It's an interesting one. I mean, there does seem to be evidence, that very many neuropsychiatric conditions tend to be associated more with cortical deficits than with subcortical deficits, and the evolutionary newer brain regions. And they also seem to be, especially prefrontal regions, seem to be more related to, let's say, individual differences than subcortical regions. So, to me, I mean, obviously this is a bit of a trite response to your question, but it's very much an empirical question, and it should be quite easy. And we try to do this with some of our multivariate analysis, where we will see, can we distinguish, it doesn't matter, cases from controls, using just the cortical measures or using just the subcortical measures. Now, it's a slightly biased comparison because there are more cortical regions given standard segmentations than there are subcortical, but generally we have better success in those discriminations with the cortical regions. But that said, there are much more sophisticated measures. I think that's what you're alluding to as well. So with the diffusion spectrum imaging, so we get much more in-depth measures of sort of intracellular, extracellular, neurite measurements. And those I've seen papers more recently from the ABCD study that are really implicating, regions like ventral striatum. I think of that was like in eating disorders. So I think it's an open question as to which, where the action lies. And no doubt it's ultimately going to be a bit of both, as is always the case.
We'll take one more question from the auditorium if there's anyone who's got a burning question. Lady at the... Wait, no, lady at the back.
Thank you, great talk. I was interested in hearing if it applies to the research in the ABCD study. Does the study group include children from communities with less exposure to social media or digital world, like Amish or Mormon communities? And do these children have different impulse and decision-making responses?
Yes, so it is interesting. You know, a few years ago, if you were doing a study on adolescent development and you talked to parents, as you know, you might imagine the first question they'd ask is, well, what does alcohol or cannabis or cigarettes do to my kid's brain? Absolutely not anymore. The first question they ask is, what does screen media activity do to my kid's development? So we have extensive measurements on it. And I actually have a colleague back at Vermont who's got a grant solely to study these questions with this data set. You know, it's unclear. It's horribly complicated, right? Because, and I'm sorry, this is a long-winded response to your question, because it's very hard to determine cause and effect. It's very heavily confounded if you're spending a lot of time doing screen media activity. Are you having less physical exercise, poorer sleep? What's driving the effects? And so on and so forth. But there are approaches to getting at this. There's even some evidence that you know, some kind of expanding screen media activity might have some cognitive benefits. So some of these games, if you've seen them, are extraordinarily complicated. So there's evidence on some of these tasks actually where we've seen people's ability on inhibitory control tasks is better the more these kind of, you know, immersive games people play. Now, those immersive games then also, the more you have it, the higher you score on mental health conditions. But we even see some sort of titration. If you have like maybe 1 hour or so, which I think is kind of the recommended level, you see actually some of those cognitive benefits. And again, I'm being very causal in my language. You see some of those cognitive benefits and you don't see the mental health deficits. But this is an active question with the ABCD study, because the beauty of it is that we have these longitudinal data. So we can see, you know, screen media activity at time point, is that predictive? And last thing, and then I promise I'll shut up and yield the stage, we can exploit the twin study. So we can look, and this is very, very useful, because as you know, like there's tons of research showing associations between mental health and screen media activity, but inferring causality is really challenging. But we have identical twin sets who are discordant for screen media activity, and we're finding that level of discordance is related to mental health discordances. So, you know, as best we can, some evidence implicating screen media activity causally with actually negative mental health outcomes. But yeah, it's an ongoing, there's already hundreds, probably about 100 ABCD papers on just this question.
Great, thank you.